Did you need to go over things you said, or you already kind of gave a debrief?
So gave a little update. So yeah, we'll just kind of roll through. Carly's going to go through each of the questions. If you guys have questions, just raise your hand and we can just kind of pause as we go. And don't be afraid to ask questions, because if you have the question, probably somebody else does too. So this is really your time to like get all the knowledge, discuss all of the things, all of that good stuff. Okay.
Absolutely. Okay, 1 second. Let me just, okay, can you see the test? The test is pulled up. Medication administration management. Are you seeing that? Sorry, I can't see you guys. Okay. Okay. All right. So yeah, just like Jordan said, we're going to go through. I'm going to go over some of the, I'm going to go over all of the correct answers, and even going over the answers of, why these certain answers aren't correct. And again, we just wanted to be able to, record so that you guys can, if you would like this recording to go back and study, have a little bit more understanding, knowledge, or questions for us. We're here for all of that, and we've got the recording for you. So our question number 1, you're admitting a neonate from FCC with suspected sepsis. What answer is true? So the correct answer here is going to be, I will prioritize obtaining a blood culture when inserting a PIV sterilely on admission before infusing antibiotics. Really the main thing here is prioritization of the culture. We would never give antibiotics before that culture because then the culture is not going to be accurate. And then blood glucose, we do care about that, but it is not the baby's number one priority. CBC and type and screen, we also care about that. But when thinking about our labs and prioritization, culture is going to be first if that's something that we need. But for, suspected sepsis, absolute priority. Then our CBC, type and screen, and blood glucose will come prior to that. So question number 2, you're admitting a 32-week infant with a maternal diagnosis of choreo. What is the medication that you would anticipate the provider to order? So AMP and Gent, that is our broad spectrum antibiotics that we start with all of our kiddos here in the NICU. Vancomycin is going to be something that's a little bit more consistent with things that are like resistant, antibiotic resistant drugs. Hydrocort we'll get into what we use hydrocort for. That's not something that we would do for choreo. Caffeine is, again, something we'll get into in our other questions, but not our priority for our broad spectrum antibiotics for our choreo babies. So AMP and Gent is our answer there. You have ampicillin ordered for midnight. Where would you expect this medication to be located, and how will it be prepared? So the correct answer here is going to be in the Omnicell drawer, the vials that contain ampicillin powder that will have to be reconstituted at bedside. So really just want you guys to know where to find, especially in an admission situation. AMP is going to be the one that we can pull from the Omnicell drawer, while gentamicin is the one that will be made up by pharmacy and will be sent up through the tube station. This question here for our answer here, D, a pharmacy tech will bring that medication to the NICU. That's going to be more for your controlled substances. So your fentanyls, your Verseds, things like that are going to be made up and brought up by a pharmacy tech, and you'll have to sign those off. Really, again, just want you guys to know like what medications, if you're starting a certain medication or need to give it, how that is going to be brought to the NICU. Okay, question number 4. Your patient is 3.5 kilos. Your dose of ampicillin is 100 milligrams per kilo. The concentration of AMP is 100 milligrams per ml. How many mLs of ampicillin are you going to give your patient? Please show your work. So really, this is just about, starting with your weight of your baby of 3.5 kilos, bringing in that dose of the 100 milligrams per kilo and really ending in that concentration to bring your mLs in to end in the total number of mLs that you are going to be giving your patient. And that final answer is going to be 3.5 mLs. For the med math, of course, it's a little difficult for me to show you like how to do the med math via, the Teams meeting. But if you are noting that a lot of the med math questions you got wrong, please reach out to us. Please talk to us about, maybe a one-on-one coaching with the medication calculations. If there's something that you're missing, something that you're not feeling like you're getting right. I feel like some of the questions that were answered incorrectly were based on rounding, which we'll get into those questions. I feel like most people got this 3.5 mLs correct. There's some other questions later in the test where rounding does really become a factor, especially in our patient population where rounding to the incorrect decimal place is a cause for a very serious safety error. And that if we round too much, then that's going to give that baby way too much med. So we'll get into that, those specifics in later questions. And then question number 5. So please explain how to reconstitute AMP and prepare. Really, guys, and that's why we put this nice little picture here. We were really just looking for you guys to tell us that, we only do IV ampicillin in the NICU. We were really just looking for you guys to tell us that you dilute with the 4.7 mLs of the sterile water flush for that to make that final concentration of 100 milligrams per ml. And some of you were even thoughtful to do the math again and put that you pulled up 3.5 mLs. Love that. Also just adding that you do like the nice roll and rotate to dissolve that ampicillin powder. Any questions I'll do like a little pause at like those 5 questions. Any questions there? Okay, so question number 6. So on admission in our NICU, how is gentamicin administered? So some of you that got your notes back did note, or we put a note in there that if you got this question wrong, we did remove this question from the test. Because this is a recent change on our unit. I believe that the presentation that was printed off by Lisa prior to me being able to update the presentation, because a lot of you were very thoughtful in the test you wrote. On the presentation, it says to give slow IV push, but on Neofax, it says 30 minutes. Thank you for doing that and as we were seeing that a lot of people got this question wrong, I was trying to figure out where the miscommunication here was. So we removed this question from the test, just so you guys know. But the change, the new evidence-based practice for on admission when giving gentamicin is to give it over the 30 minutes on a syringe pump. We used to give this slow IV push to kind of reach that, golden hour, get the medication in before our golden hour was complete for our babies. But new evidence-based practice has shown that it's actually best to give that loading dose of AMP over 30 minutes. So that is the correct answer to this question. Okay. After initial admission dose, so all of the subsequent doses of gentamicin prior to the admission will be also given 30 minutes on a syringe pump. Okay, so on to our next questions. Your intubated patient has IV fentanyl, 1 mic per kg every 2 hours, PRN ordered. If your patient's weight is 2.3 kilos and your concentration is 5 mics per ml, then you're going to use that information to answer the questions 8 through 13 on this page. So how many mLs of fentanyl are you to administer for your patient for each dose? So really here, we were just looking for you guys to write out the med math, the medication calculation here, starting with your weight of 2.5 kilos, again, going to your dose, 1 mic per kg. You get that 2.3 mics per dose. Then you bring in your mLs of 1 ml per 5 mics, and you will get the final result of 0.46 mLs. Again, med math, I know it's a lot to just for me to talk at you with that. So just knowing that if you were having trouble with the med math, bringing in your dose and your concentrations, please just talk to us. We're happy to do a one-on-one coaching with you. Okay, so how will you administer a fentanyl bolus? So the correct answer here is going to be C, a slow IV push over 10 minutes, flush 0.8 to 1 ml slowly at the same rate. Um, really, like looking at the other answers here, I will say that on Neofax, this may have been, tripped some people up, but it does say over 3 to 5 minutes. So just with that feedback, we are going to be changing this answer to over 3 to 5 minutes, just so that's not, but if you really look at these other answers, this is really the only one that is truly appropriate. Giving a fentanyl bolus over 30 minutes or 60 minutes is way too long for fentanyl to be effective. Fentanyl is very short acting. If you give it over 30 to 60 minutes on a syringe pump, it's not having that desired effect of giving your baby pain management. And then B, the baby needs pain control as soon as possible. Rapid flush, absolutely not. There's only two medications that we rapid push here in the NICU, and that's going to be your like meds that you're giving in a emergency, an MSET, so epi, and adenosine. So we should never be rapid pushing any medications, especially fentanyl. A rapid push of fentanyl is going to send your baby into having chest wall rigidity, which is a very scary thing to see. So again, only appropriate answer here is slow IV push over 10 minutes. Um, what is the possible side effects to monitor for administering fentanyl? So straight off of Neofax, respiratory depression, hypotension, and chest wall rigidity are the three things that you are going to want to monitor. Be very cautious about your push rate, and just keep an eye on your babies for. You call your provider because your patient continues to fight against the ventilator and tries to grab the tube. The provider increases your PRN IV fentanyl dose, but also adds a PRN midazolam. What is midazolam versus used for? So big thing here, again, straight off of Neofax, but also off of our presentation, our medication administration presentation. It's used to treat agitation, decrease anxiety by inducing sedation. It's not a narcotic, but it's a benzo. So really just wanting you guys to know that when you are, you have PRNs of fentanyl and midazolam, that they are used in two very different ways. One is used as a sedative to decrease that anxiety. But if you're just giving a sedative and you're also doing something painful and you're not giving your fentanyl, you're not giving that baby proper pain management. So just making sure that you guys have that knowledge. Okay, so the dose of PRN IV midazolam is ordered at 0.1 milligrams per kilo, and the concentration is 1 milligram per ml. How much will you give and how will you administer it? So really, this question is kind of a twofer of doing the correct math, but then also knowing how to properly give the medication. So doing the proper medication calculation, you're going to get the total of 0.23 mLs. And then you will always be giving that over a slow IV push of 5 minutes. Again, never rapid pushing anything in the NICU unless it's epi or adenosine. And then C and D are wrong because it is the incorrect volume. All right. Number 13. So midazolam is incompatible with lipids. Your patient currently has TPN and lipids running through a single lumen PIC. Assuming additional lines are not available or able to be obtained, which is the following method to administer this medication? The correct answer we were looking here for is to clamp your lipids, flush your extra port with 1 ml flush to clear the line, give your Versed, flush the 1 ml to infuse that medication and clear the line, clamp your red port, and unclamp your lipids. Really like looking at, the other three answers just are not appropriate, in that intralipids being a continuous infusion that you can give intermittent medications is inappropriate, in that they are not compatible. This will clog your line and clot off your PIC, which would not be good. So B is inappropriate. Call the providers to switch your intralipids to SMOF, also inappropriate. SMOF lipids are only for our babies that have, any kind of GI disorders going on. We would not just switch a baby from intralipids to SMOF just because they're incompatible. There is no other option. We need to get another pick ASAP. Also inappropriate. We would never just put another pick into a baby, increasing their risk for eclampsia, because they have these two things running, when we have this very, wonderful process of being able to just flush the line, clear, give your medication, and then clear it again before starting your lipids. Any questions for the questions 8 through 13 that related to your fentanyl and Versed? Okay. So you're admitting a patient with possible seizure activity from the PACU. On admission, you notice rhythmic movement of the arms and legs, tongue thrusting, and abnormal eye movements. You immediately inform the provider, and when examined, they decide to order a bolus of phenobarb. Your patient is 3.5 kilos. You use that information to answer questions 14 through 17. So a lot of these questions were, straight off of Neofax. The loading dose of phenobarb, that is going to be on the first page of Neofax that you pull up for dosing. Loading dose of phenobarb, correct answer there is 20 milligrams per kilo. What is the ordered concentration of phenobarb? I feel like sometimes a lot of people will play around with Neofax to find this correct page, but it is on the admin page of Neofax under the final IV concentration, giving you the correct answer of 65 milligrams per ml. How will you administer the phenobarb loading dose? Again, you will find this on the admin page in Neofax. It does say 15 to 30 minutes on Neofax, but again, just looking at all of these other answers, they would be inappropriate. The correct answer is going to be over 30 minutes on a syringe pump. 10 minutes way too fast. We never do rapid push, and then a slow IV push also not appropriate. Needs to be on a syringe pump over that 30-minute time frame. How many mLs of phenobarb will you administer to this patient? Show your calculation below. This is one that I feel like people did miss because of rounding errors. So you will start with the weight of your baby of the 3.5 kilos. Again, going to your dosing of 20 milligrams per kilo, giving you 70 milligrams per dose. When you bring in your concentration of 1 ml per 65 milligrams, then you will get the total of 1.076 mLs. Really the biggest thing, and I can write that 0.76. So biggest thing here, the correct answer that we were looking for is 1.08, rounding to that hundredth place. A lot of people did put 1.01. That is rounding to an inappropriate amount for our patient population, and then that would be way too much phenobarb to give. We're also not leaving to the thousands, as it's not like this is kind of inappropriate to leave, in that we should just be rounding that 7 to 1.08 mLs. Okay. So just making sure that you're rounding appropriately, round to the 100th place, please. Okay, so question number 18, what signs and symptoms should you be monitoring for phenobarb admin? So please choose all that apply. The correct answers we were looking for here are respiratory depression, apnea, and hypotension. I feel like a lot of the people that missed this just did not circle the apnea piece. So the biggest thing in our patient population that we do look for with a phenobarb, when we are starting phenobarb, we will see apnea. I know that goes kind of hand in hand with respiratory depression. This was more something that we talked about in our presentation and in the small groups preps with Jordan. But really the biggest thing is that when you are looking for this respiratory depression, that what we're looking for in our patient population is actual apnea events. Any questions on those are all any questions on the phenobarb questions? Wonderful. Okay, so you are admitting a transport 2-week-old, 27-week gestational age infant from a neighboring hospital with acute respiratory distress. The infant is admitted onto the jet. PIP is at 38. Our PEEP is at 13. We have a rate of 300. I time of 0.020. Our FiO2 is at 100%. We have nitric oxide that we've started at 20 parts per million. You're reviewing your orders and see the provider ordered IV hydrocortisone, 1 milligram per kilo every 6 hours. The hydrocort concentration is 1 milligram per ml. The infant weighs 1.2 kilos. So please use this information to answer questions 19 through 20. So why did the provider order hydrocort? So this was something that we talked about in our presentation together that I gave during one of your system classes. The correct answer we're looking for here is A. So it increases the expression of androgenic receptors in the vascular walls, increasing the vascular reactivity in hypotensive babies that are hydrocortisone deficient. So again, we really want you guys just taking the knowledge away of what hydrocort is doing. I feel like a lot of people automatically think that it's has something to do with building up a steroid for the lungs, which that's really not the role of this medication. If you look in your presentation that we gave for the medication admin for your system class, we talk about it there, but this mechanism of action is right in Neofax. So just making sure that you have that knowledge of what hydrocort is being ordered and used for in our patient population. For our patient population, how would you administer hydrocort? So this is just right off of Neofax, IV push over 3 to 5 minutes. Again, this is kind of just eliminating the inappropriate answers here. 15 to 20 minutes, way too long and unnecessary. And then IV rapid push, again, not something that we do. Any questions on questions 19 through 20? Wonderful. Okay, so you're taking care of a patient on NIPPV receiving continuous feeds via transpyloric tube, an OD tube. Your patient also has a gastric tube to vent the stomach and for medications. You're planning for your 3 a.m. hands-on care and you look at the MAR to see you have multiple medications due. Please use this information to answer questions 20 through 23. So we've got morphine every 4 hours, multivite with iron once daily, sodium chloride every 12 hours, and caffeine once daily. So after confirming the concentrations and doses of each medication in Neofax, what other resources can you consider for these PO medications? And the correct answer here is the osmolality chart in Canvas. So answer A. So then the next question is asking what is the appropriate, after using the appropriate resource, what is the appropriate route to be giving these medications? So this is something we did want you guys to use the osmolality chart in Canvas, but we also wanted you guys to take away the things that we talked about in small group. These were questions in the Jeopardy game you guys played with Steph on Monday. Really just taking into account all of the information and doing a little critical thinking. So morphine is hands down inappropriate to give transpylorically. It's way too harsh to put into the small intestine, so you will always be giving that gastric. It's one of the red meds that is totally inappropriate to do transpyloric. If you are giving morphine and you're giving it on an empty stomach, just being thoughtful that if you are giving it into the gastric tube, that you're mixing it in with a little bit of milk. Giving morphine on an empty stomach, just not something that we would like to, can be irritating to our babies' stomachs. Multivite with iron. So this is the one that a lot of people missed in that they put it would be appropriate to give gastric. Same concept for morphine in that we do not want to be giving this this medication on an empty stomach. There on the medication osmolality chart, it does have it does have on there that when giving EPO, it is inappropriate to administer that medication into the stomach. But just knowing that Epogen is not something that we use very sparingly on our unit now. So it would be appropriate to give this medication transpylorically. That was the answer we were looking for, and things that we talked about in presentation, Jeopardy, small groups with Jordan for prep. Sodium chloride, that is going to be given transpyloric, OD, and caffeine, OD as well. I feel like a lot of people just answered this question, didn't read the circle OD or OG. So they just answered, you guys selected a question. So just knowing that here we were looking for each of these medications, how were they given?
Caffeine is OD or OG.
Sorry, I couldn't hear the question. Was there a question?
What is that she gotta have? Is that OD or OG?
Which one?
Caffeine.
Caffeine is OD.
Thank you.
Yeah.
I'm so sorry, I couldn't hear any of that. Okay, was the question answered though?
We're good, carry on.
Okay, awesome. Sorry, guys. Okay. And then question number 23. So explain how you will give your OD PO medications at the 3:30 feeding time. So really the big things here that we were looking for were that you are going to mix the medication into the feed, that you are not just pushing the medication into that transpyloric feeding tube. So with OD tubes, we are pushing these medications, or we are mixing these medications into the feed because this is a very sensitive area. It's the small intestine. It doesn't have all of that protective lining and enzymes that are in the stomach. So we really need to be mindful of how we are giving these medications. Again, we're never just pushing them. That's just way too harsh on that small intestine. We need to mix those medications into the feed. Some of you guys were very thoughtful. I loved the answers that some of you gave where you said you'd push out a certain mLs of milk and then put your medications in. So knowing that that feed was going to run over the appropriate 4-hour time frame of your continuous feed so that no milk or med was wasted. Also putting the label of that medication on the feeding syringe, because it's very important if your feeding pump starts going off, maybe reading occlusion, and somebody just comes in and turns off your pump. It's usually a big red flag for us as nurses if we're going in to help, turn off a pump in a room. If we see a label on a feeding syringe, we automatically know there's a medication in that feeding syringe. So we're not going to just turn that off. So really just making sure that you're doing your due diligence of, one, not only mixing the medication in the feed, but you're also putting your labels on your syringes. Really quick, sorry, someone came into the office. I don't know if I had just said this, but I wanted to just make sure to go back to cover the multivitamin with iron. We are working with our pharmacist, Diane, who was on UBC, you guys saw. We're working with her to kind of update that osmolality chart so it's a little bit more clear now that we're really very, very rarely using Epogen in our patient populations. That the multivitamin with iron is, we have that on there, that it's appropriate to give transpyloric. But really just, again, it's that critical thinking aspect of, would you want to give a multivitamin, but no less, especially with iron in it, on an empty stomach? That's really going to give some GI distress to our babies. Sorry if I'm repeating myself on that, but just wanted to cover that because I know that was a question that some people missed. Any questions on the transpyloric meds or feeds? Okay, wonderful. All right, so question number 24. So you're taking care of a 2-week-old 28-weeker. They're scheduled for caffeine every 24 hours at 1 a.m. The order states that the dose is 10 milligrams per kilo and the concentration is 20 milligrams per ml. Your infant is 0.85 kilos. How many mLs of caffeine will you be administering? Show your work. So again, this is just showing your medication calculations and med math, starting with your weight, your dose, going to your concentration to end in mLs, and then ending at 0.43 mLs. What is the mechanism of action of caffeine? Again, just talking to you guys like in our teaching rounds and overall just with any kind of medication education, we want you guys to have a deeper understanding of what these medications are doing for our patients and how they're really their mechanism of action, how they're working in our babies. You know, I feel like a lot of times we will say, you know, telling mom and dad this is a medication that reminds your babies to breathe, which yes, that's something that you can say to parents, but really the correct answer here is that it's a CNS stimulant and a cardiac muscle stimulant. Really, when actually looking at answer B, that it stimulates the lungs to breathe, the caffeine actually works as a bronchiosmooth muscle relaxant. So that's really not how it's working at all. It's a CNS stimulant that is talking to the baby's brains and overall just making sure that that cardiac muscle is being stimulated and those smooth muscles in the lungs are being relaxed so that the lungs can do its job and we can eliminate or reduce our apneic events in our patient population. And then these other two answers are just incorrect. But this answer also is directly found on Neofax in the mechanism of action page. What type of patients are we using are we putting on small lipids instead of intralipids? So the correct answer that we were looking for here is any patient with GI issues, perforations, neck, liver dysfunction, because it may reduce the inflammation. This was something that was directly taken from our presentation, our medication administration presentation. Question number 27. So you're admitting a 33-week gestational age infant. The first blood glucose is 38. The provider orders a D10 bolus. What is your dose of D10 for a 2.5 kilo infant? I feel like we've said this till the cows have come home, guys. So we've talked about it in like starting day one in your small groups. We talked about it in the medication administration, talked about it yesterday in our admission scenario. So I feel like we've tried to, you know, bring this up a lot. Things I really want you to know off the top of your head so that when you are in admission, there really is nowhere to find, like there's no resource that says what our dosing is for D10. So you really need to put to memory that 2 mLs per kilo, our babies are too sweet, 2 mLs per kilo for D10 bolus. 28 is just answering off of question 27. So doing the medication calculation for your baby of 2.5 kilos, that's going to give you the correct answer of A, 5 mLs. Where can you find your D10 fluid bags? So really just wanted to, for you guys to know where you can find the fluid bags, especially during an admission, that you not only can find it in clean holding, this is correct, but you can also find it in our IV carts. I think some people missed that you could choose all that apply. So we were looking for IV cart and clean holding. How will you administer your D10 bolus? So correct answer here is going to be slow IV push over 1 to 5 minutes. These other answers are just inappropriate by elimination. 10 over 30 minutes, over 60 minutes, that's inappropriate for a baby that has a low blood sugar on admission. We need to get that bolus in over a 1 to 5 minute time frame. This is actually now what you will see in your MAR order set. It will say over 1 to 5 minutes, and that's a new update from our providers within Epic. And then rapid IV push is inappropriate.
Carly, I wanted to add one thing too, just to help you guys when can you hear me okay over there? Carly?
What? I can hear someone. Is that Jordan?
Yeah.
Yes, okay.
Just wanted to put just as a nice reminder. So thinking about when you're in an admission, if your baby has a low blood sugar, oftentimes we're already starting nutrition, right? We're hanging D10, we have that kind of maintenance fluid running. So if your blood sugar is so low that they're like, we want that maintenance fluid and a bolus, we're not going to put the bolus over a pump, right? That bolus is going to be like an additive, a quick, yes, we're getting this in plus the maintenance fluid that's hanging. So if that helps you remember, this needs to be slow push, not over a pump. That's how I like to remember it. if that's helpful for you guys.
I can hear you now, Jordan.
Did you hear that explanation?
Yes, I did. Yeah, that's wonderful.
Okay. That's all.
Okay, perfect. So now question 31. So you're admitting a 40 weeker that is 4 kilos with a maternal history of a partial abruption. On admission, the infant is pale with low BPs. It has taken multiple attempts to get access on this infant. What would you expect the provider to order? So we talked about this in our admission scenario yesterday, as well in the medication administration lecture. So we're always going to be giving full normal saline. I like to put this question in here, guys, because we do have half normal, so 0.45 normal saline bags on the unit. I want you to know the correct bag to grab. So it would be inappropriate for us to be giving a bolus to this baby of 0.45 normal saline. We need that full normal saline bolus to help with that overall perfusion and hypotensiveness. And then D10 and hydrocodone, inappropriate answers. So again, correct answer here, 0.9 normal saline bolus. Then going off of that question, what is the ordered dose for your medication for question 31? So 10 mLs per kilo. Again, things that we've talked about along with the D10 dosing. You want your baby to be at the perfect 10, so 10 mLs per kilo for your full normal saline bolus. And then just doing the medication med math right off of your 10 mLs per kilo for our baby is going to give you the answer of 40 mLs. Okay. So that's all I got. Any questions on the medication debrief?
Really quick, before we get into questions, I just wanted to add, I know that this isn't a question on here, but just so that you guys aren't confused, when you're giving a normal saline bolus, that is always, again, common admission med that we give, but that's always going to be given over 30 minutes to an hour. And just kind of thinking about the context that we just gave with the D10 bolus, normal saline bolus isn't going to be for that blood sugar. It's not going to be in conjunction with the fluids that we're already running. So that's why we don't slow push the normal saline bolus. That will be given over a period of time, depending on how big your baby is. Okay? I know it's not a question, but I just didn't want there to be any confusion.
Yeah, no, that's a great point.
Yeah, any questions from any of this? Anything sparked? No? Helpful? Yeah, okay, cool. Okay, great. Carly, anything you want to add?
I don't think so. I think I talked enough. But any questions you guys have, I'm happy to answer them.
Going once, going twice. All right, I think we're good.
All right.
I'll see you in a little bit.
All right.